Good morning, good evening, and welcome to another intensivecare@home.com live stream. Today's topic is C1 and C2 spinal cord injury, ventilation, tracheostomy at home care with 24/7 intensive care nurses. My name is Patrik Hutzel from intensivecare@home.com and intensivecarehotline.com, and we help families of critically ill patients in intensive care to make informed decisions, have peace of mind, control, power, and influence, making sure their loved ones always get best care and treatment so that you can have real power in challenging ICU situations, making sure your loved one always gets best care and treatment. So, if your loved one is critically ill in ICU with a C1 or C2 spinal cord injury or is already at home, but with insufficient support on a ventilator with a tracheostomy, then this live stream is for you. Today, I'll be talking about what you must know about C1 and C2 spinal cord injuries in intensive care, why 24/7 intensive care nurses, also known as CCRNs, are essential for these patients, and most importantly, how clients with ventilation and tracheostomy can safely transition with 24/7 ICU nurses through intensive care at home, living a much better quality of life with community access and patient and family involvement. Now, also make sure you like this video, subscribe to my YouTube channel, hit the notification bell, and share this live with anyone who's got a loved one in ICU. Now, also, I want to welcome the viewers on replay, because I know we get quite a number of views on replay. So I want to welcome all of our viewers there. But if you are joining this live, this is your option and your opportunity to ask questions or throw in a super chat if you want to, and ask questions here. Now, also, what makes me qualified to host a YouTube live like this, talking about C1 and C2 spinal cord injuries in ICU as well as home care, spinal injuries with home care. So again, my name is Patrik Hutzel. I'm a critical care nurse by background, having worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com, and I've been the founder and managing director of intensivecareathome.com since 2012. I've got decades of intensive care nursing experience as well as decades of intensive care at home nursing experience, so I can have the ability to bridge both worlds, which is critically important for our clients and their families. Now, with intensivecarehotline.com, we are consulting and advocating for families in intensive care all around the world. We have saved many lives with our consulting and advocacy, and you can verify that on our intensivecarehotline.com podcast section, where we've done client interviews, and you can also verify it on our intensivecarehotline.com testimonial section, where we've got dozens, if not hundreds, of testimonials of our clients. With intensive care at home, we are looking after long-term ventilated adults and children with tracheostomies at home, and we've been doing so since 2012. We are the only service in Australia that is third-party accredited, that has the intellectual property as well as the setup and the staff to look after intensive care at home patients, long-term ventilation, tracheostomy for adults and children, BiPAP, CPAP ventilation at home for adults and children, tracheostomy care at home for adults and children without ventilation, home TPN, home IV potassium, home IV magnesium, home IV antibiotic infusions, central line, PICC line, Hickman's line, port management at home, cough assist management at home, ventilation weaning at home, nasogastric tube, nasotracheostomy, PEG tube, PEG tube management at home, as well as palliative care at home. That's intensive care at home in a nutshell. We also provide level 2 and level 3 NDI support coordination, TAC and WorkSafe case management, and that's WorkSafe Victoria. So, we can help you with the advocacy of what you need as well. So let's start with the C1 and C2 spinal cord injury, what that actually means. The C1 and C2 vertebrae are at the very top of the spinal column, right under the skull. They control neck movement and breathing function. When someone sustains a C1 or C2 spinal cord injury, it often results in complete paralysis below the neck and an inability to breathe independently, meaning they require mechanical ventilation. These patients are neurologically intact above the neck in many cases, meaning they can still think, feel, and communicate, but they are completely dependent on ventilation support. So what are challenges in ICU, in particular ventilation, tracheostomy, and decision making? In ICU, doctors will often say things like, there's no quality of life, they'll never come off the ventilator, or it's time to withdraw treatment and donate organs. And I can tell you some real case studies here. We have 2 C1 ventilated clients in the community, and I can tell you firsthand, both of those clients' brains are intact and they have every will to live. But here is what I tell you what both of those clients have shared with us. One client's parent has shared with us that, as soon as their child went into ICU with a C1 spinal injury, they were told, we should just stop everything and we should just donate organs. And, because their child wouldn't have any quality of life if they were to survive. Now, nothing could be further from the truth. This person has a very good quality of life in the community, wants to live, has community access every day, has a stable critical care nursing team around them. But, the parent was absolutely shocked when they were told, do you want to donate organs for your child? And, the response was, how do you dare asking me for my child's organs in case of making sure my child can live? Right? I think intensive care units have to rethink their approaches in many cases, and because that's simply not the right approach. Another one of our C1 ventilated clients has the following story to share. This client was injured when he was 6 years old. He was in a terrible car accident at the time, and he sustained a C1 spinal injury when he was 6 years old. He ended up in ICU, and again, the parents of the client, said to their child at the time, well, if you want to leave us and go to heaven, blink once. And if you want to stay with us and you want to live, blink twice, because he couldn't talk. And you know what he said? And I didn't stop blinking. Right? So, and this particular client is now in his 40s and he lives a very good quality of life. There's some videos of his life on YouTube. I'm obviously not sharing people's names here, but I can tell you this particular gentleman is living a very good quality of life. He's an ambassador for people with a disability because he's overcome so many challenges, and he's a really good advocate, but also a role model for anyone living with a disability. So these are 2 examples that whatever you're experiencing right now, if you have a family member in ICU with a C1 or C2 spinal injury, there's hope. There's quality of life on the other end. If you get the right level of support, the right level of funding, the right level of advocacy, and funding is nowhere near as daunting as you think it is, because with intensive care at home, we're saving about 50% of the cost of the ICU bed. Also, both of these clients have regular community access. They live with their families, and that's why they report a good quality of life. So that's why many patients with C1 and C2 spinal injuries can have a good quality of life with the right long-term care and ventilator and tracheostomy support. Because a tracheostomy is a very viable option with C1 and C2, it's actually the only option for patients to survive long term. Because it allows for long-term mechanical ventilation, improved comfort, easier communication and care, and obviously it allows for discharge from ICU with intensive care at home. However, families are rarely told that ICU is not the only option. That's where we come in. At intensivecarehotline.com, we help you advocate, speak to ICU teams directly, get access to all medical records to help you make informed decisions about tracheostomy, ventilation, and care options long term. And you can book a confidential call at intensivecarehotline.com with me so we can help you take control right now. Now, let's look at common ICU pressure tactics and how to respond. ICUs often pressure families to quote unquote let go because they think long-term ventilated patients have no quality of life. And what is quality of life? Quality of life is no more than a perception. And your perception of quality of life might be different than my perception, right? And that's just a matter of fact and needs to be accepted as is. So I've seen hundreds of cases where families were told their loved ones won't survive, they'll never leave ICU. If they do leave ICU, they need long-term care, they won't have any quality of life, blah, blah, blah. And yet, with our advocacy and expertise, many of our clients have been successfully discharged home with intensive care at home, where they live fulfilling lives. But many patients outside of C1 and C2 spinal injuries have also been successfully discharged from ICU, without needing intensive care at home. Many of our clients have used our service, just for advocacy. And we have saved, like I said in the beginning, we have saved hundreds and hundreds of lives in intensive care just with our consulting and advocacy alone, because we understand intensive care inside out. That means that gives us leverage in helping you manage intensive care teams. You don't even think it's possible to manage intensive care teams. Well, I can tell you that's not the case. We manage intensive care teams all the time. And don't let ICU dictate the outcomes. Your loved one has options. Let's face it, a C1 or C2 spinal cord injury does not mean the end. It just means a different type of care. And that care can absolutely happen at home with the right setup, right? And also with, C1, C2 clients, sometimes even C3 clients, they sometimes stay at home for weeks and months, sometimes even years, right? One of our C1 clients was in hospital for about 18 months before transitioning home, right? So that's how long sometimes treatment can take to prepare patients for home care as well. So now that we've covered what's happening in ICU and how to steer the ICU territory, tracheostomy and long-term ventilation, let's talk about how home care can work safely and successfully for ventilated and tracheostomy clients with C1 or C2 spinal injuries. Let's move to what we do with intensivecarehome.com and talk about how we bring ICU-level care into the home with 24/7 critical care registered nurses. So, why intensive care at home works? At intensivecarehome.com, we provide evidence-based home mechanical ventilation services following the mechanical home ventilation guidelines, which are evidence-based. So what do I mean by that? Evidence-based mechanical home ventilation guidelines means that, some research has been done about what's the best setup for home care when it comes to ventilation and tracheostomy. And that research comes out of over 25 years of intensive care at home nursing in Germany, which is where I first worked with intensive care home services. And now we've verified that those guidelines work in Australia since 2012, because those guidelines are the gold standards. And like I said, they are also evidence-based. And what that means is that exclusively critical care nurses with a minimum of 2 years critical care nursing experience with a critical care qualification, with a postgraduate critical care nursing qualification, are safe to look after ventilated and tracheostomy clients at home, but also for ventilated clients without a tracheostomy, such as BiPAP, CPAP, or even for tracheostomies without ventilation. It needs to be 24/7 intensive care nursing, which is similar to a hospital as well, right? So we are the only provider in Australia that has actually brought standards into the community by standardizing intensive care at home, right? All other providers are trying to undermine and don't have standards, don't have the intellectual property, don't have the policies and procedures. And they're trying to, cut corners, and people have died because of that. And I have evidence for what I'm saying here. So our clients on tracheostomy and ventilation have 24-hour intensive care nursing support. All of our intensive care nurses, of course, are trained to manage ventilators, airways, and tracheostomies, of course. This isn't conventional home nursing, it's intensive care home nursing following international evidence and best practice and standards. Now, let's look at quality of life at home versus ICU. At home, our clients have community access. They go out, go to the movies, go shopping, visit friends, attend family gatherings. They live with their families, not in isolation in ICU or in a nursing home or in other facilities. They have continuity of care with ICU-trained nurses. They know, like, and trust. What that means is, we're building stable teams around your loved one's care. Your loved one sleeps in your own bed, not under fluorescent hospital lights. We've seen C1 and C2 spinal injury clients who were bedridden in ICU now living at home, interacting with family, going outdoors in their wheelchairs, all while being safely ventilated and supported. That's quality of life. And that's why intensive care at home exists. But that's also why, we help ICUs to free up their in-demand ICU beds much quicker than usually. And ICUs can stop talking about end of life. They can talk about quality of life, not about end of life. They can stop about organ donation, and talk about quality of life. Now, don't get me wrong, organ donation has its time and its place, but not for C1 or C2 ventilated clients that actually want to live. The first question that needs to be asked in ICU is, does your family member want a tracheostomy? Or if they can't make the decision themselves, do you as a family give consent to a tracheostomy? So now let's look at evidence, funding, like NDIS, TAC, NISQ, iCare, and so forth. Now, we work with funding bodies like the NDIS, TAC, DVA, and other insurers to make 24/7 ICU nursing at home fully funded. Like I said, everything we do is evidence-based, as outlined in our published and evidence-based home mechanical ventilation guidelines on our website that are linked towards. We also liaise with hospitals to transition patients home safely. So if your loved one is in ICU with a C1 or C2 spinal injury, a tracheostomy, and ventilation, you have a choice. Stay in ICU indefinitely or go home with intensive care at home and have quality of life again and have meaning in life, right? So remember, with C1 and C2 spinal cord injuries, life doesn't stop in ICU. With the right setup, ventilation and tracheostomy care at home are absolutely possible and safe with 24/7 ICU trained nurses, right? Also, I give you another example. Our very first client in 2013, it's one of the clients that I was talking about in the beginning. He had a support worker model at home on a ventilator with a tracheostomy. Now, let me be very clear. A support worker model for someone on a ventilator with a tracheostomy is like flying the airplane with the cabin crew instead of flying the airplane with a pilot. It is a death sentence. The reason I'm saying that and using those words is that patients have died under a support worker model at home when it comes to ventilation and tracheostomy, right? It is absolute madness to even think about that, right? People have died under support worker models, and I have plenty of evidence to support everything that I'm saying here. Now, if support workers could work with ventilated and tracheostomy clients safely, why is there no evidence for this? And why don't we have support workers in intensive care? Right? So that's what I'm saying. That's why it's so important that we are the only provider in Australia that has actually brought in standards into the community, right? Evidence-based standards, more importantly. Now, also, when it comes to providing evidence that 24/7 intensive care nursing is needed, right, we also provide, like I said in the beginning, NDIS level 2 and level 3 support coordination. We're also providing TAC and WorkSafe case management, right? And that's where we help you provide evidence. We also have a network of ICU doctors, ICU nurses that can help with writing reports, right, to support your case. But if 24/7 intensive care nursing wasn't funded, we wouldn't exist, because there's not only a very strong human argument for it, there's also a very strong economic argument for it, because it doesn't matter whether it's the TAC, the NDIS, ICARE, NISQ, and so forth. The bottom line is that we are cutting the cost of an intensive care bed by 50%, right? So that's the bottom line. Now, yes, so coming back to our very first client that we were looking after at home, he is a C1 ventilated and tracheostomy client. He had a support worker model, and he had a few general RNs in the mix without ICU experience. And lo and behold, he did not stay at home predictably. He was more or less living in ICU because, of course, support workers could not keep him at home predictably and permanently. How could they? They don't have the skills and the expertise to look after a ventilator and a tracheostomy, full stop. So, therefore, we had the opportunity at the time to prove our model. And proving our model, we did in no time, literally within a couple of weeks, right? When we worked with this client, or since we've been working with this client, he never, ever went back to ICU ever again, right? And that goes without saying. You know, we're bringing the intensive care into the home and not, not have people live in ICU. So the model works. The model has been proven beyond the shadow of a doubt. We have now provided millions of hours of intensive care at home nursing, right? And the model has been proven beyond the shadow of a doubt. Intensive care at home has been around in Germany since the late 1990s. It has been around now in Australia since 2012. And, the model is clearly a model that works. And also want to say that if you're watching this and if you are in the UK or in the United States, we have a lot of inquiries from both countries. please keep reaching out to us. We can often point you in the right direction, or we can help you on a private basis by hiring private nurses wherever you are in those countries, right? So in any case, C1, C2 ventilation with tracheostomy in ICU is not a death sentence. There are clear pathways, proven pathways for clients to go home, and I encourage you to reach out at intensivecareathome.com to make that transition, to get the funding if funding is the issue, and we're looking forward helping you in your situation. Go to intensivecarehotline.com if you're stuck in ICU, or go to intensivecareathome.com if you're at home already or you want to go home. If you don't have the right level of support right now at home with support workers, or you're going back to ICU all the time for chest infections or for any other complications, reach out to us. We can help you improve your life, your quality of life, and get the right staff and also get the right level of funding if that is what you want. Now, if I'm going to wrap this up in a minute, now it's your time to ask questions. If you have any questions, you can talk to me live on the StreamYard link here that I just posted in the chat pad, or you can type your questions into the chat pad and talk to me right there. Now, in the meantime, I will answer a few other questions that have come in during the week, for example, from Lola, who says, "Hi, Patrik. It's really an emergency. The ICU doctor said that my husband only has a slim chance of being weaned from his ventilator and tracheostomy. They don't think they can wean my husband off a ventilator and the tracheostomy. He's been on a ventilator now for 45 days, and now they don't think he can be weaned off at all. Many different ICU doctors and ICU nurses come and go. There's no consistency. They want to send him to rehab, but we don't think that'll help. So they're talking about palliative care. I just don't know what to do. Can we take him home with intensive care at home and have a consistent team of ICU nurses we can trust? Please help. I want you to call the doctors and ask him questions. Thank you for all you and your team do." So Lola, this situation is unfortunately very common in intensive care. After 45 days of ventilation and tracheostomy, it's not unusual for ICU teams to lose hope and push for palliative care or rehab, when in reality there are alternatives and they're simply not telling you about it. The reality is many long-term ventilated patients can't be weaned in ICU, not because it's impossible, but because the ICU environment isn't designed for long-term care. Patients are often surrounded by noise, bright lights, constant staff changes, and an impersonal atmosphere. That's where intensive care at home comes in. We're the only specialized service in Australia and beyond that provides 24/7 intensive care nurses in the home for patients on tracheostomy and mechanical ventilation, BiPAP, CPAP, non-invasive ventilation, tracheostomy care without ventilation, long-term oxygen therapy or high-flow nasal cannula, home TPN, home IV potassium, home IV magnesium, home IV antibiotic infusions, central line, PICC line, Hickman's line, port management at home, and so forth. So with our service, your husband can be safely discharged home from ICU and continue his ventilator care and tracheostomy care in a much more stable and familiar environment, his own home. Here's why this works so well. There's less infection risk. Home environments have far fewer infections than ICU. Your husband will be much safer at home. He will have a better quality of life. He'll be surrounded by family, not machines and strangers. Continuity of care. You'll have a consistent, experienced team of ICU nurses, not a revolving door of staff. He'll have ICU-level care. Our nurses are all critical care trained and deliver the same high-level care your husband gets in ICU. And it's hospital and ICU bed substitution. We work under, like I said, the mechanical home ventilation guidelines that are evidence-based and partner with hospitals' funding bodies, TAC, NDIS, to make safe discharges home possible. So yes, you can absolutely take your husband home with intensive care at home instead of sending him to rehab or being pressured into palliative care. We provide the skills, the equipment, the ICU nursing expertise, the medical cover to make that happen safely. So that's it for today. I'm going to wrap this up here today. Look out for my quick tip videos during the week. Like, comment, and subscribe to my YouTube channel. And more importantly, share this video with anyone that will benefit from this. If they have a loved one in ICU or at home that need a higher level of support, we can help you very, very fast. I'll do these YouTube lives every Sunday, 10:30 a.m. Sydney, Melbourne time, which is currently 6:30 p.m. Eastern Standard Time in the United States, which is 3:30 p.m. Pacific time. Thank you very much for watching, and I'll talk to you again next week. Take care. Now, with intensive care at home, we are currently sending our ICU and critical care nurses into the home 24 hours a day. We are providing the following: home care services for ventilated adults and children with tracheostomies with critical care nurses 24 hours a day. A genuine alternative to a long-term stay in intensive care or long-term acute care, tracheostomy care for clients without ventilation, home care services for patients on non-invasive ventilation such as home BiPAP, home CPAP, home TPN, which is also known as IV nutrition, home IV potassium and home IV magnesium infusions, IV fluids, and IV antibiotics. We are providing central line management, PICC line management, Hickman's line management, as well as port management at home. We're providing nasogastric tube and PEG tube management at home, the use of cough assist machines for our clients for airway clearance at home, palliative care services at home, as well as ventilator weaning at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That also means we're in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day, and we're freeing up the most sought after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families, which is a win-win situation for all stakeholders. Of course, quality of life is much improved surrounded by families and by a team of dedicated intensive care nurses in the home care setting instead of in an intensive care unit. With intensive care at home, we are currently operating all around Australia in all major capital cities as well as in all regional and rural areas. We work with NDIS clients all around Australia, TAC and WorkSafe in Victoria, Department of Veteran Affairs all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are having policies and procedures for intensive care at home nursing, and we've built all the intellectual property for intensive care at home since 2012. No other provider in Australia has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. So if you're at home already, and if you're watching this, or you're stuck in an ICU long-term, or if you're going to hospital and ED all the time, and you realize that you don't have the right level of support at home, or if you are stuck in an ICU, I'll give you a real-world example today how we can help you. One of our first clients when we first got started in 2012 was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, support workers are not equipped to look after a client at home on a ventilator with a tracheostomy. That is dangerous and it's simply negligent. Having support workers looking after a client at home on a ventilator with a tracheostomy is like flying the airplane with the cabin crew instead of the pilot. Because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at high risk of dying if they don't have a team of dedicated critical care nurses looking after them 24/7 at home. This is actually evidence-based and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after your critically ill loved one or after any critically ill patient on a ventilator with a tracheostomy. So why would anyone in their right mind do that in a home care environment in the community? So this client at the time found out about us eventually, and the ICU that he was basically living in also knew about us and eventually reached out to us. And we were proving our concept with this client very fast. When we worked with this particular client, we sent him critical care nurses 24 hours a day, and he never ever went back into ICU ever again, as long as we were working with this client. We can do the same for you if you're not safe at home and help you with keeping you at home predictably. Otherwise, we would not be in business. Again, the same is applicable for those stuck in an ICU, similar to this case study that I've just given you. Or if you're going back to ED all the time, please reach out to us. We can help you with taking you through the right steps, including how to get funding with different funding bodies. This is also why we are providing NDIS support coordination. We have a team of NDIS support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Richards, one of our NDIS support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCodder. If you're an NDIS support coordinator or a case manager from another organization watching this and you're looking for nursing care for your participants, please reach out to us as well. If you need more evidence for nursing care, we are also writing NDIS nursing assessments with legal nurse, critical care consulting nurses. If you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic, and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. You can join this high-performing team if you are a critical care nurse. If you are looking for a career change as a critical care nurse, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, in Warragul, in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I do have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again because they are so vulnerable and so special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts and you're really keen on building solid relationships with us and with our clients. If you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost-effective than what you're paying for in ICU and ED, and you get the same level of care. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, or for home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US and in the UK, and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrik Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.